So good morning all. So the talk is patient with tense abdomen, high pressure with or without organ failure. So I'm going to talk about intra-abdominal hypertension and abdominal compartment syndrome in this talk. So abdominal compartment syndrome is organ dysfunction caused by intra-abdominal hypertension. It is under-recognized because the patient with ACS are already very critical, and the organ failure will thought to be because of the progression of primary disease. The timely treatment can improve organ dysfunction. Untreated abdominal compartment syndrome has mortality of around 100%, and patient admitted in medical or surgical ICU, 0.5 to 8% of patient may progress to abdominal compartment syndrome, and it is highly studied in trauma patients, and the incidence is about 14%, and 58% of patients admitted in ICU have intra-abdominal hypertension. So I'm covering definitions, incidence, risk factors, clinical presentations, diagnosis, management, and prognosis of IH. So these are the definitions given by World Society of Abdominal Compartment Syndrome. So first, intra-abdominal pressure. It is a steady state pressure concealed within the abdominal cavity. For critically ill patient, it is 5 to 7 millimeter of mercury, and the normal range is not applicable for all the patients, and morbidly obese and the pregnant individual can have chronically elevated intra-abdominal pressure as high as 10 to 15 millimeter of mercury without adverse sequelae. Second is abdominal perfusion pressure. It is similar to cerebral perfusion pressure. It is mean arterial pressure minus intra-abdominal pressure. So elevated intra-abdominal pressure reduces blood flow to the intra-abdominal viscera, and a target abdominal perfusion pressure of at least 60 millimeter of mercury is correlated with improved survival from intra-abdominal hypertension and ACS. So intra-abdominal hypertension, it is defined as sustained intra-abdominal pressure more than 12 millimeter of mercury. It is graded into four: grade 1, 2, 3, and 4. Grade 1 is intra-abdominal pressure between 12 to 15 millimeter of mercury. Grade 2 is between 16 to 20 millimeter of mercury. Grade 3 is 21 to 25 millimeter of mercury, and grade 4 is more than 25 millimeter of mercury. Now hyperacute intra-abdominal hypertension, it lasts for seconds due to laughing, coughing, straining, sneezing, defecation, or physical activity. Acute intra-abdominal hypertension develops over hours, a result of trauma or intra-abdominal hemorrhage, and can lead to the rapid development of ACS. Subacute intra-abdominal hypertension develops over days. It is most common in medical patient and can also lead to ACS. And chronic IAHs develops over months, as in pregnancy, or years in morbidly obese patient, and it does not cause ACS but does place the individual at risk for ACS if they develop superimposed acute or subacute intra-abdominal hypertension. Abdominal compartment syndrome, it is defined as a sustained intra-abdominal pressure more than 20 millimeter of mercury with or without abdominal perfusion pressure of less than 60 millimeter of mercury that is associated with new organ dysfunction. For clinical purpose, ACS is better defined as intra-abdominal hypertension induced new organ dysfunction without a strict intra-abdominal pressure threshold, since no intra-abdominal pressure can predictably diagnose ACS in all the patients. So a patient with IAP less than 10 generally do not have ACS, and if it is more than 25 millimeter of mercury, usually have abdominal compartment syndrome. So patient with an intra-abdominal pressure between 10 to 25 millimeter of mercury may or may not have ACS, depend upon the individual variables such as blood pressure and abdominal wall compliance. So, uh, So, intra-abdominal hypertension, when it is pressure increases more than 10, and if it is more than 25, it converts into the ACS. So, being intensivist, we should target this area. We should treat in this area. Otherwise, the organ dysfunction progresses, and once there is organ dysfunction, there is high risk of mortality. So the possible organ dysfunction on various intra-abdominal pressures at 7 to 11 millimeter of mercury, splanchnic hypoperfusion, 11 to 18, elevated airway pressures, reduced cardiac output and oliguria. At 18 to 25, hypotension, hypercarbia, hypoxia, anuria, and increased intracranial pressures. And if it is more than 25, multi-organ failure. So these are the various risk factors. Diminished abdominal wall compliance, as in trauma, burn, prone position, abdominal surgeries, increased intraluminal content in gastroparesis, gastric dilatation, ileus, colonic pseudo-obstructions and volvulus, increased intra-abdominal contents in pancreatitis, distended abdomen, hemo and pneumoperitoneum, intraperitoneal fluid collections, intra-abdominal infections or abscess, intra-abdominal or retroperitoneal tumors, and peritoneal dialysis. Capillary leak and fluid resuscitation in acidosis, damage control laparotomy, hypothermia, massive fluid resuscitation or positive fluid balance, polytrauma. Other includes bacteremia, sepsis, pneumonia, increased head of bad angle, and massive incisional hernia repair. So the society guidelines recommend measuring IAP when any known risk factor for intra-abdominal hypertension is present in a critically ill or injured patient. So we have to measure in all these risk factors, patients with all these risk factors, we should measure the intra-abdominal pressure. So it is classified into primary, secondary and mixed. So primary ACS is injury or disease confined to abdominal pelvic region that frequently requires early surgical or radiological intervention, as in pancreatitis, liver failure with massive ascites after abdominal surgery, and massive retroperitoneal hematoma. Secondary ACS refers to conditions that do not originate from the abdominal pelvic regions, as in sepsis and capillary leak. Major burns condition requires massive fluid resuscitations. And recurrent ACS refers to the condition in which ACS redevelops following previous surgical or medical treatment of primary or secondary ACS. So persistence of ACS after decompressive operations and development of new ACS after definitive closure of abdominal wall after previous temporary abdominal wall closure. So these are the various mechanisms: increase abdominal volume, decrease abdominal wall compliance, and combination of both. So increase abdominal volume in gastrointestinal tract dilatation, as in gastroparesis, gastric distension, ileus, volvulus, colonic pseudo-obstruction, intra-abdominal or retroperitoneal masses, ascites or hemoperitoneum, pneumoperitoneum. And decrease abdominal wall compliance, as in the abdominal surgery, especially with tight abdominal closures, abdominal wall bleeding or rectus sheath hematoma, surgical correction of large abdominal hernias, and combination of both, as in obesity, sepsis and septic shock, severe acute pancreatitis, massive fluid resuscitation, major burns, and complicated intra-abdominal infections. So this is the pathophysiology. So in critically ill patient, we start resuscitating with fluid, which increases the total body water, and which leads to third spacing and peripheral edema, and which elevates the intra-abdominal pressure. So if IAP exceeds 15 to 20 millimeter of mercury, capillary blood flow is dramatically reduced, leading to anaerobic metabolism, increased cytokines and production with capillary leaks. And if it is more than 20 millimeter of mercury, it causes vena cava compression, which reduces preload to the heart, and reduce the cardiac output, further reduce the perfusion of organs, and leads to multi-organ failure, and it becomes a vicious cycle. So it affects intra-abdominal hypertension affects from the brain to the toe. So here's various effects on systemic effects on of IAP. So in brain it increases intracranial pressure, decrease cerebral perfusion pressure. In lungs it decreases chest wall compliance, elevate diaphragm, increase intrathoracic pressure, increase peak inspiratory pressure, increase dead space, hypercarbia and hypoxia. In cardiovascular system, it decreases venous return, increase CVP and PAOP, increase SVR, and decrease the cardiac output. In abdomen, it decreases abdominal perfusion pressure and mesenteric venous blood flow. So it decreases the bowel perfusion, and which leads to bowel ischemia and inflammation, bacterial translocation and cytokine release, and which further increase the intra-abdominal pressure. So it again become a vicious cycle. And in renal system, it causes oliguria, decreased GFR, and proteinuria. And in lower limb, after IVC compression, it causes edema and increased risk of DVT. So how we measure the intra-abdominal pressure? There are direct intra-abdominal pressure measurement, direct needle puncture and transduction of the pressure within the abdominal cavity, as in peritoneal dialysis or laparoscopy. Intermittent indirect IAP measurement, transduction of the pressure within the bladder, and continuous indirect intra-abdominal pressure monitoring by balloon tipped catheter in the stomach or a continuous bladder irrigation method. So the various routes are intraperitoneal drains and probes, gastric, intravesical, IVC, and uterus. But the intravesical is the gold standard. So the tools to use for measurement of IAP should be accurate, reliable, and reproducible. So intravesical IAP measurement is gold standard, and it depends on Pascal's law. So how many of you measure intra-abdominal pressure in their ICU? Regularly? In all the patient with risk factors? Okay. So it should be measured, always measured in millimeter of mercury. It should be measured at the end of expiration in supine position and absence of muscle contraction, and it should be zeroed at mid-axillary line and after installation of 25 ml of sterile normal saline. So where you transduce the transducer in this for measurement of at phlebostatic axis. It should not be measured at phlebostatic axis. It should be measured at the iliac crest where it crosses the mid-axillary line. Always we should zero the transducer at the mid-axillary line where it crosses the iliac crest. Okay, so in this what we do, we claim the drainage catheter, urinary drainage catheter just distal to the aspiration port. We insert a 18 gauge needle through the aspiration port, instill 25 cc of normal saline, and we measure the IAP at the end of 30 to 60 seconds. We wait for 30 to 60 seconds for measurement. After that we should measure it. Okay, so the IAP pressure waveform has inspiratory and expiratory variations. So it increases during expiration decreases during inspiration. Expiration, and increases during inspiration. So we should always measure our IAP at the end of expiration, and there is oscillation test positive, and it is reproducible over the several minutes. So what is the stepwise approach to manage a patient with ACS? So we consistently repeating serial IAP measurements optimizing systemic organ perfusion, identify any organ dysfunction, and targeted measures and procedures to control IAP and decrease potential damage, and quick surgical decompression when it is warranted. So it is the society ACS society algorithm. Uh, so this is for intra-abdominal hypertension. If patient has IAP more than 12, so initiate treatment to reduce the IAP and monitor IAP every 4th hourly till the patient till it becomes less than 12. So we have to monitor every 4th hourly. This is the society guidelines of IAP measurement. And the medical therapy options we have, they have described it in five points. First is improve abdominal wall compliance, evacuate intraluminal content, evacuate abdominal fluid collections, correct positive fluid balance, and organ support. So first, evacuation of intraluminal content, it decreases the intestinal volume, that decreases the intra-abdominal pressure. So by nasogastric tube decompression, putting rectal tubes, medicines to increase gastric and colonic motility like neostigmine and or gastric motility prokinetics, and minimize enteral nutrition and extra flushes can give enemas, colonoscopic decompressions, and if it is not improving, then discontinue all enteral nutrition. Second is evacuation of intra-abdominal space occupying lesion. Find and evacuate problematic fluid, tumors or hernia. Do ultrasounds and CT scan to find all these collections, and percutaneous drainage if there are any collections, and surgical evacuation. Improve abdominal wall compliance, which allows the compensation of increased intra-abdominal pressure. So adequate sedation and analgesia, which is very important. Remove constrictive dressing and address scars. If head of head elevation should be kept less than 30 degree, or we should keep the patient flat or in Trendelenburg positions. We can use paralytics if it is not improving. And optimizing fluid balance and administration, avoid excessive fluid resuscitation. Our goal is to do zero balance or slightly negative by the day 3. Further resuscitation with hypertonic or colloid solutions. If patient is stable, remove fluids by giving diuretics, hemodialysis or CRRT. And optimizing systemic and regional perfusion, deliver adequate oxygen content and blood flow, and to increase organ perfusion. Always give goal directed fluid resuscitation, evaluate for fluid responsiveness, and try to increase the cardiac output. Optimal ventilation and alveolar recruitment, hemodynamic monitoring, and if required, use vasopressors and inotropes. If despite it, if IAP is more than 20 with new organ dysfunction, it strongly consider the surgical decompression. So the guidelines suggest use of PCD to remove fluid in those with patient when it is technically possible, compared to doing nothing, or compared to immediate decompressive laparotomy, as this may alleviate the need of decompressive laparotomy. If CT there is ascites or any pancreatic fluid collections like this, we should drain them by putting PCDs. And damage control resuscitation is increasingly being used among the critically injured patient, characterized by permissive hypotension, limitation of crystalloid and intravenous fluids, and delivering higher ratio of plasma and platelet to RBCs. And the society does not recommend using diuretic RRTs and administration of albumin to mobilize the fluid in hemodynamically stable patients, and they don't recommend use of abdominal perfusion pressure in the resuscitation or management of critically ill or injured patient. So if patient developed ACS, then we should perform this or revise abdominal decompression with temporary abdominal closure as need to reduce IAP. So surgical recommendations are patient undergoing laparotomy for trauma suffering from physiological exhaustion be treated with the prophylactic use of the open abdomen, and it is not recommended in non-trauma patient. So they suggest not to routinely utilize the open abdomen approach to patient with severe intra-abdominal contamination undergoing emergency laparotomy for intra-abdominal sepsis. The longer the abdomen is open, the greater the potential of morbidity. Thus, specific strategies should be utilized from the first laparotomy that consider prevention of visceral adhesion, loss of soft tissue coverage, lateralization of abdominal musculature and its fascia, malnutrition, and enteric fistulas. And conscious and protocolized effort be made to obtain an early or at least same hospital stay, hospital abdominal facial closure. Now, negative pressure wound therapy involves applying some degree of suction to an open abdominal wound through use of visceral drips and constant negative wound pressure. This technique prevents visceral adherence to anterolateral abdominal wall while maintaining medial facial traction, which enhances facial closure rate among those with open abdomen. And it is always recommended in critically ill injured patient with open abdominal wounds. So it looks like this. There is a drape and the suction, negative suction apply over it, and there is a seal. So this is the second algorithm which shows the management of ACS. So if they have the same in 5 points, they have managed a stepwise approach to the ACS patient. First is evacuate intraluminal content, evacuate intra-abdominal space occupying lesion, improve abdominal wall compliance, optimize fluid administration, and optimize systemic and regional perfusion. So step 1 is insert nasogastric or rectal tubes, initiate gastric or coloprokinetic agents, abdominal ultrasound to identify any lesions, ensure adequate sedation and analgesia, remove any constrictive dressings, avoid excessive fluid resuscitation, and aim for zero to negative fluid balance by day 3, and goal directed fluid resuscitation therapy. And step 2 is to minimize enteral nutrition and administer enemas, abdominal computed tomography to identify any lesions, consider reverse Trendelenburg position, resuscitate using hypertonic fluids, and hemodynamic monitoring to guide resuscitation. And step 3 is consider colonoscopic decompression, consider surgical evacuation of any lesions, consider neuromuscular blockade, and consider hemodialysis or ultrafiltration to remove any additional fluid. After all these 3 steps, if IFE still persists more than 20 with new organ dysfunction, then if patient is refractory to medical therapy, strongly consider surgical abdominal decompression. So this is point of care ultrasound in monitoring of intra-abdominal hypertension. This is recently added in the society guideline. So if it is high, then the same 5 points they have considered. The step 1 is by doing ultrasound, we can confirm the nasogastric tube position. We can assess any gastric contents, detect or quantify volume of abdominal fluid, measure abdominal wall thickness, ultrasound to assess any cardiac dysfunction, and assessment of renal, hepatic, and portovenous blood flow. Step 2 is assess degree of bowel activity and dilatation or any feces, identify need of enema therapy, USG guided percutaneous drainage, and detection of there is any abdominal wall movement on ultrasound, and US for IVC and fluid assessment, and calculate renal resistive index. And we can use the ultrasound to assess the patient at risk of IH and ACS by using point of care ultrasound. So finally, it is the critical pressure beyond which intra-abdominal pressure increases very rapidly. So we should use any all the effort we should make to decrease the intra-abdominal pressure, which further reduces the progression of organ failure. So if it increase organ failure worsens, then there is a high mortality. Uh, so this is all about the intra-abdominal hypertension. Thank you. Any questions?
So we break for